from a practical standpoint, the data with maintenance EGFR is lacking to the level that we have with VEGF inhibitors. I don't disagree.
It's not even necessary to do anti-EGFR
well, we don't know
maintenance.
that. We don't know. Well, yes, we do.
Well, can I drill down on
Right.
what do you do in that situation? So if you start with EGFR,
Right.
this is something I don't do very often. So, and it's 8 months down the road. Do you switch to a sort of a Bev capecitabine maintenance? Do you maintain the EGFR single agent? What's sort of the practice strategy for those who would, are doing this in the front line? How do you handle it?
Do oncology as we do oncology. Treatment as long as you do have a benefit or as long as the patient has,
So you
let's say,
keep
the
it
will
going
to
as
follow.
long as they can tolerate
and
it.
the median treatment duration in these trials was not more than 6 months.
Yeah.
Yes, I do not say do stop every patient after 6 months, but consider the patient's interest and potentially
Any
after this
maintenance
treatment.
or stop them cold and
no
wait?
Maintenance.
No maintenance.
You know, in real life, in Europe, even with bevacizumab, even let's say in mutant patients where you don't have the problem alternative, in real life maintenance is not very often done.
Yeah.
So in most of cases between 6, 7, 8 months, you stop everything because the patient is fed up of treatment. You have reached the maximum efficacy that you can reach with first line. We are working in a system where is 99% or 100% public health system. And so there is not, the interest is on the opposite side because basically you have space for more patients if some stops. And in medium sites or community hospitals, this is a key issue because basically you have day hospital places taken by patients that are forever without knowing. Preferentially, I do bevacizumab treatment as long as necessary as possible, but I'm in a minority in my country. In terms of anti-EGFR maintenance, actually there are some data.
Yeah, there are.
For example, there is the data of the Macbeth randomized phase 2 trial in which a modified FOLFOXIRI was added to cetuximab and then as maintenance after 4 months of chemo. Chemo was stopped and either bevacizumab or cetuximab was given to the responding patients. And this is from the Gono and Falcone study in Pisa. And there is a trend in favor of cetuximab over bevacizumab. So also, if you do the maintenance, is not totally true. But there is another reason that anti-EGFR treatment could be done in a pulsatile way. Because if it's through the biology of the emerging clones with RAS mutations and they disappear as long as you don't treat the patient with anti-EGFR because there is no biology pressure any longer, one of the reasons why in third, fourth, fifth line anti-EGFR treatment could work in patients that responded in earlier lines could be that now you have again clones that are RAS and RAF responsive. And so this is not very easy. And then the story between bevacizumab and anti-EGFR in first line is a classical story between Americans and Europeans.
Well, so a couple of quick points. There is not enough evidence for EGFR maintenance as you have with bevacizumab. And I totally agree. The difference, and that's why I started the first point, it's practical and pragmatic.
Yeah.
Our practices are very different, and they rely on different ways to actually treat patients, how we view maintenance, how we view long-term treatment versus our European colleagues. So the nuances on the left are not as significant as the nuances on the right. And therefore, when you take this whole package in terms of how I treat my patient in clinic for 2, 3, 4 month difference, I actually take the route that actually makes it the easiest to treat my patient for the longest time. And that's the nature of our practice, which is different.
So we
than
can
our
agree.
European
We can
colleagues.
agree to be different on that. But I think the
But we don't disagree
lesson,
on the principle.
No, the lesson I think really is that we are increasingly enriching the patient who benefits from EGFR therapy.
Yes.
Right.
And this right versus left clearly helps us do that. And I think it's a perfectly appropriate discussion that the patient should be engaged in about risk and here's what our curves look like and toxicity and public versus the other counter argument of simplicity and we're in this for the long haul kind of strategy. And I think this is really important because we're now taking off the table some patients who were getting EGFR therapy and we're enriching for this group. And the second is that then biologics have a clear role. So that's part of our job is to find right patient, right